So hello everyone, welcome to the Terminology Leading Practices stream of SNOMED CT Expo 2023. So my name is Sarah Warren and I'm a terminologist at SNOMED International. I will be moderating today's session. So all questions will be answered at the conclusion of the presentation. For online attendees, please use the Q&A button to type your questions to the presenter. For on-site attendees, please use the microphone in the middle of the room. So I'm now pleased to introduce Robert Wynne from the National Library of Medicine, who will be presenting lessons learned from instantiating the SNOMED CT International Medicinal Product Model with RxNorm drug products. Robert, over to you.
Thank you. Good afternoon, everyone. Today we're going to speak about the lessons learned from instantiating the International Medicinal Product Model with RxNorm drug products. With Olivier Bodenreiter, who is at a workshop right now, so I'm standing in. This is a standard disclaimer. The views that I express are not reflective of my government, and we have no conflicts of interest to declare. So this slide is a little busy, though it describes a little bit of previous work where we analyzed the SNOMED model and the RxNav model. We expected them both to be interoperable, and we came to that conclusion. Now we have to compare the instances. So RxNorm asserts equivalences by key pair values. As you can see on here on our RxNav browser. A browser isn't a model, but it's a good visual representation of a SNOMED CT clinical drug that we map to in the SNOMED browser. And that's a manual mapping. So we're trying to answer, is this really a good quality mapping? So RxNorm does share definitional features or predicates, if you will, if you're an OWL fan, with SNOMED CT sufficient to build classes. With both the SNOMED CT and RxNorm drug product defined in OWL, we would expect the reasoner to find these classes equivalent. What is a reasoner? A reasoner is able to inspect OWL for equivalences, among other things. So I won't go too deep into these methods, though in order to complete this, what did we do? We created logical definitions in OWL for each RxNorm generic drug product. We need to keep in mind that these are generic drug products. We are not mapping brand or packs. And then we classify these definitions using the OWL2 EL reasoner, ELK, together with the OWL version of SNOMED CT. When the OWL was finished, ELK inferred logical equivalences and the corresponding products in SNOMED CT. We then compare these equivalencies to asserted equivalencies in RxNorm. What did we find? Well, here's an example concept. Some of you may not be familiar with protege. Here's a protege view. We're going to use an example from our previous slide, atorvastatin 20 milligrams. In the equivalent class, we see that we are equivalent to SNOMED's product containing precisely FSM, the ID. And we also see in the protege 5.5 hierarchy, the equivalency sign, which is good news too. So the results of 6,150 about RxNorm products with asserted equivalences to SNOMED CT were at about 76% equivalent by the ELK reasoner. For the others, however, the 24%, there was one or more errors in the definition that kept us from creating an equivalence. So we observed that the following types of errors: ingredient issues, dose form issues, and strength issues, which we'll get into in a little bit. Ingredient issues: different basis of strength substance, different active ingredients, and overlap. Dose form issues: this is a custom dose form mapping for this process because we do not have, well, let me correct that. We do not equate both dose forms on both sides exactly 1-to-1. So many of these dose form issues were with injectables. For instance, an auto injector in RxNorm is not represented efficiently in SNOMED CT. Strength issues, different units, different unit values, and some overlap again. Here are some examples of ingredient issue examples of basis of strength substance. As you can see, in columns 2 and 3, we underline these differences. So this is just a simple table. You can see varying dose forms and their ingredients. So for example, at the very bottom, related to another talk from earlier, sodium fluoride, we have an RxNorm. However, in SNOMED CT, the boss is fluoride ion. How do we understand one ingredient in RxNorm is equated to a substance in SNOMED CT? Well, that's an editor decision. So going from RxNorm to SNOMED, this is what we find. Remember, we're going from RxNorm to SNOMED. We're not going to SNOMED CT to RxNorm. More ingredient issue examples dealing with active ingredients. Some of these have to do with salts of hydration. Let's see if we can find a good example. Zofran, Rethrate. So we see SNOMED has odenosestron hydrochloride, and RxNorm active ingredient is odenastrin. Dose form issue examples. This is where it gets a little tricky. So from our previous example, going with the same generic, we want to apply a delayed release oral capsule as a gastro-resistant oral capsule. However, SNOMED has conventional release oral capsule. The more difficult dose forms, injections, injectable solutions. We would expect solution for injection. Sometimes we find solution for infusion. Injection, we find powder, solution for injection. And on the other side, we have solution for infusion. Eye drops. RxNorm, we have ophthalmic solution, where SNOMED has eye solution. These are just cherry picked. At the very end of this process, what do we get? We get a QA byproduct. We get a full report of all issues found by ELK. We dig into the equivalent class itself and compare it to both sides. Strength issue examples. These are minute. There's very few of them. We have different units and we have different values. These can be considered rounding mistakes or editorial policies. Findings. This is very encouraging. We're at 76%. Because the OWL definitions for RxNorm products are generated completely automatically. However, the error analysis points to remaining issues mentioned before: ingredient issues, dose form issues, and strength issues. Finally, we found it difficult to determine if a unit of presentation needed to be defined for a given manufactured dose form. Unit of presentations are not in RxNorm. And when I say they're not in RxNorm, I say they're not denominator units. quality assurance. This is perhaps one of the best things that ELK can give us. We get as I said earlier, a QA report is generated. And this QA report that we look at, we're able to observe all 6,500 clinical drugs in RxNorm that have an asserted relationship to SNOMED CT. If it's asserted, we know it's asserted. If it's also inferred, we also know it's inferred. Also, we're able to infer something if it's not asserted. We found this to be the case for about 150 RxNorm clinical drugs. So assuming the mapping process is accurate, failure to infer equivalence between an RxNorm product and its SNOMED CT equivalent may be due to an error in RxNorm or SNOMED CT, less likely in both. And we have found anecdotal evidence of such errors, which we have reported to the developers of both RxNorm and SNOMED CT. Interoperability. Because we have in fact, a prototype extension for RxNorm drugs, we made it possible to represent RxNorm drugs with the same formalism as SNOMED CT drugs products. We made RxNorm drugs interoperable with SNOMED CT drugs. Therefore, this work is a contribution to terminological interoperability demonstrated in harmonized concept models that integrate SNOMED CT, LOINC, and RxNorm. Limitations. This prototype extension for RxNorm drugs we developed is experimental and might not be available for future versions of RxNorm. And as mentioned earlier, we only covered generic drug products. We don't do branded drugs or packaging informations or packs. So conclusions. This demonstrates the feasibility of instantiating the SNOMED CT International Medicinal Product Model with RxNorm drugs products, with accurate OWL definitions automatically generated for 76% of the RxNorm drug products. It also highlights remaining issues related to ingredients, dose forms, and strength differences between RxNorm and SNOMED CT, thus providing an opportunity for quality assurance. And any questions?
Yes, thank you very much. Maybe after Peter, yeah.
Okay.
Yeah, go ahead, Peter, yeah.
Thank you very much. I'm really pleased to see this work. Since day one that Peter Williams, SNOMED International.
Oh, great to meet you.
Since my first day here, I've really been aware of the fact that until we have something to compare our work to, we have no idea if it's right or not. You know, I can write a report and the data's there. If I don't have someone else doing the same thing, I have absolutely no clue about it. So I suppose my question is, have you considered automating this? Like we're going to do another release every month. What SNOMED International would love to see is someone who was willing to compare it each time, so we can put these through and then, you know, whitelist the ones we've seen before and say, no, we've dealt with that. But new things, the sooner we can get that information through, the better.
Yeah, great question. So we run this every month with SNOMED CT International, RxNav REST API with the SNOMED CT International. So you're always getting the latest and greatest content.
Awesome. Thank you.
Mm-hmm.
Hi, this is Guillermo Reynoso. We worked with Olivier many years towards developing the international drug model. And part of the interest was in validating, you know, content in the international drug model, finding gaps, coverage issues. And have 3 or 4 direct questions. The first one is, in your percentages, you say 76%, but that probably is more than 90% in discrete dose forms, and probably more problems with the liquids dose forms and the representation. And it was not clear from your presentation whether you got towards the concentration and strength only for liquids, and how you found that. That's my first question. The other is, it will be quite interesting if you find any gaps in the substances, the content in substances that are used in the US, that, you know, those are reported and added to SNOMED if necessary, because coverage issues either in those forms, but mostly in substances, are extremely costly for maintenance. Thank you very much.
Sure. Your first question had to do with presentation and concentration on templates. So when I first received this project, I had the IDMP and editorial guides thrown at me. So going through those and looking at them, we needed to compare our dose forms, oral solid dose forms, for example, to what was in the guide. Most of those were presentation, probably in fact all. However, concentrations were a little bit more difficult. Let's see if I can find an example. Off the top of my head, though, some liquids, topical sprays, for example, those were tricky. Tinactin, I guess, it would be one. You have talc, but it's in an aerosol can and maybe loaded with other inactive ingredients. How to do that? And your second question had to do with substance mappings. Again, these are SME curated, and those are substance mappings map not only to the substance in SNOMED, but also to the medicinal product. Sure.
Any other questions in the room before we move to online questions? No. Okay, so online, we've got what technologies were used?
Well, we can't get away from Java. That's the big one. And we couldn't have done this without the SNOMED to OWL converter. So those are the big two. But for RxNorm, we needed the RxNav REST API. And we also have the ELK reasoner and Protege as our dashboard.
Thank you. And last question, what strategy do you see moving forward to add mappings and reconcile issues?
I'm not in a position to answer this, though I would say write your senator, maybe your ambassador, I don't know. We would really like to get both sides together for a cohesive strategy with someone possibly in the middle being able to take a liaison position, though all of this is still in discussion.
Thank you. One last call out for any questions in the room? No. Super. So with that, we'll conclude this session. Thank you, Robert. Online delegates can join another session through the event lobby. Thank you very much.